Assalamu alaikum. My name is Muhammad Awais. I'm one of the assistant professor in pediatric department, Akhtar Said Medical College. Our today's topic is rheumatic fever, and we'll start from the etiology of rheumatic fever. There is considerable evidence to support the link between group A, streptococcal upper respiratory tract infections, that is pharyngitis, and acute rheumatic fever and rheumatic heart disease. So we have already discussed the pharyngitis, tonsillitis, upper respiratory tract infections. So this is in connection to that previous lecture. As many as 66% of the patients with acute episode of rheumatic fever have a history of upper respiratory tract infections. So we can presume that there is a strong association between that group A streptococcus and between that acute rheumatic fever. The peak age and seasonal incidence of acute rheumatic fever are closely parallel to those of group A streptococcal infections. So, in the peak age is in the school-going children, and when the kids go to school, there is usually a classroom of 20 or 30 kids. So when they come close in one class, the probability of spreading the infection increases. And certain serotypes of group A streptococcus like M types 1, 3, 5, 6, 18, 24 are more frequently isolated from patients with acute rheumatic fever than other serotypes. So not all the serotypes of bacteria are specific for rheumatic fever, but there are certain types which are specific for rheumatic fever. And the incidence of acute rheumatic fever in some developing countries exceeds 50 per 1 lakh children. And worldwide rheumatic heart disease, which is the long-term sequelae of rheumatic fever, remains the most common form of acquired heart disease in all age groups, accounting for as much as 50% of cardiovascular diseases and as much as 50% of all cardiac admissions in many developing countries. So, what is the epidemiology of rheumatic fever? So, as we have already discussed, the characteristic group A streptococcal bacteria are important, but at the same time, characteristics of host are also important. Um, the incidence of both initial attacks and the recurrences of acute rheumatic fever peaks in children 5 to 15 years old. So that is the age when 5 years is the age when the kid starts going to the school. Patients who have had one attack of acute rheumatic fever tend to have recurrences, and the clinical features of recurrences tend to mimic those of initial attack. So definitely there is a chance of recurrence, and the recurrence would cause more cardiac damage. So regarding pathogenesis, there are two theories, cytotoxic and immunological theory. What is cytotoxic theory? This says that group A streptococcus produces several enzymes that are cytotoxic for mammalian cardiac cells such as ASO, streptolysin O, which has a direct cytotoxic effect on mammalian cells in tissue culture. Second theory is immunological theory, and that is more accepted. And as in other autoimmune diseases, you know that our body recognizes our own body tissues, which is a concept of self or non-self. So, like in other autoimmune diseases, our body starts getting reaction to our own body cells. Similar is the case with the acute rheumatic fever. In this case, like in acute rheumatic fever, there are common antigen determinants which are shared between certain components of group A streptococcus and our mammalian tissues. So there is a kind of molecular mimicry, or there is a kind of sharing of similar structures. For example, certain M types M1, M5, M6, and M6, M19 share epitopes with human tropomyosin and myosin. So not only our body reacts against the group A streptococcus, but starts reacting to our own body tissues due to the same structures of the both of the organism and our body tissues. So our body tissues start getting problem like if our body immune system reacts against our heart cells, the patient may get carditis, and if body starts getting reaction against the joint cells, then musculoskeletal cells, then the patient may present to you with the arthritis as well, and same is the case with the brain cells and skin cells. So here we can see there is a sore throat, and after 10 to 14 days of acute pharyngitis with group A streptococcus, there would be involvement of joints, heart, skin, and nervous tissue. So clinical manifestations are very important because the criteria to diagnose the disease is purely clinical. That is called the Jones criteria, and it is revised by American Heart Association in 1992. There are total 5 major and 4 minor criteria, and there is absolute criteria of group A streptococcal infection evidence, but not all of them should be present. Like 5 major, 4 minor, not all of them should necessarily be present to diagnose, but like you need definitely one minute, my mobile. So you will need definitely the evidence, supporting evidence of group A streptococcal infection in the form of ASO titer or positive throat culture. But as far as the major and minor criteria are concerned, a clinician would only need 2 major criteria to fulfill the diagnosis, or if 2 major criteria are not present, then 1 major and 2 minor criteria should be present with the evidence of preceding streptococcal infection. So this is the supporting evidence, and that is the absolute criteria. So either ASO titers would be rising or positive throat culture, and that would show us the evidence of preceding streptococcal sore throat infection 10 to 14 days back. With this, there could be major manifestation and minor manifestation. In major manifestation, out of these at least 2 should be present to make a diagnosis, or if not 2 present, as I already told you, 1 major and 2 minor. So 1 of them and 2 of them. So let's see them one by one. Major manifestation are carditis, which is pancarditis. In some cases, polyarthritis, which is migratory polyarthritis. Chorea typically is called Sydenham's chorea, Erythema marginatum, and subcutaneous nodules. In minor manifestations, there are clinical and lab criteria. In clinical criteria, there is previous rheumatic fever or rheumatic heart disease. One criteria, another is minor criteria is arthralgia, another minor criteria is fever. Acute phase reactants like ESR would be raised, or CRP would be raised, or there will be increased white cell count and prolonged PR in trouble. It is called first degree heart block. In migratory polyarthritis, what happens, like typically larger joints, knees, ankles, wrists, elbows involved. So not all the joints are involved at the same time. One joint will be involved, and after that joint, like if right knee is involved, after some days, that would be the right knee would be getting fine, and the patient is getting recovered from the right knee, but the left ankle, for example, would be involved afterwards. So the joint problem migrates from one joint to other, and the previous joint would be recovering without any treatment. 75% of the patients of rheumatic fever would get some form of arthritis. Rheumatic joints are generally hot, tender, swollen, and excruciatingly tender. Even the friction of wet clothes is uncomfortable. The pain can proceed and can appear to disproportionate the other finder. Joint involvement is characteristic migratory nature, and a severely inflamed joint can become normal within 1 to 3 days without treatment, as one or more other large joints become involved. As I already told you, rheumatic arthritis is typically not deforming. So what does it mean? Rheumatic fever arthritis is typically not deforming. It doesn't deform the joints, and the joint will come back to its original shape. There is often an inverse relationship between the severity of arthritis and the severity of cardiac involvement. What does it mean? The inverse relationship between the severity of arthritis and the severity. So the more the joints are involved, the less would be the cardiac involvement, and vice versa. So this is the this is the normal joint, and this is the inflamed, red hot and tender joint. Rheumatic carditis is characterized by pericarditis with active inflammation, myocardium, pericardium, endocardium. As you already know, the innermost layer is endocardium, that is involves and sometimes the outer layer myocardium, and the outermost layer pericardium is involved. But this not necessarily be involved in all the cases, but in some cases all the three can be involved. Cardiac involvement during acute rheumatic fever varies in severity from permanent, potentially fatal exudative pericarditis to mild transient cardiac involvement. Endocarditis valvulitis is a universal finding in rheumatic carditis, whereas the presence of pericarditis or myocarditis is variable. Most cases consist of either isolated mitral valve disease or combined aortic or mitral valve. So the most in most of the cases the valve involved is mitral valve. Valvular insufficiency is characteristic of both acute and convalescent stages of acute rheumatic fever, whereas valvular stenosis usually appears several years or even after decades of acute illness. So valvular insufficiency in the form of regurgitation, mitral regurgitation would be evident in the patient of acute rheumatic fever, but valvular stenosis like mitral stenosis occurs after decades, like it may take 10 years or around for valvular mitral stenosis to occur. Acute rheumatic carditis usually presents as tachycardia and cardiac murmurs. So sleeping tachycardia you can find in the patient who is admitted in the pediatric ward for acute rheumatic fever. You can find sleeping tachycardia. So if the patient is sleeping, you feel the pulse, there would be significant increased pulse rate, and there would be a cardiac murmur if you auscultate the precordium. Moderate to severe rheumatic carditis can result in cardiomegaly and congestive heart failure with hepatomegaly in peripheral and pulmonary edema. This is in severe cases. Carditis occurs in 50 to 60% of all cases of rheumatic fever. Rheumatic fever recurrent attacks can occur, and that can lead to carditis with associated problems as well. The major consequence of acute rheumatic carditis is chronic progressive valvular disease, particularly valvular stenosis, which can require valve replacement. Sydenham's chorea occurs in about 10 to 15% of patients with acute rheumatic fever, usually presents an isolated, frequently subtle neurologic behavior disorder. Emotional lability, so change in the emotions, like sometimes this patient will be crying and sometimes patient will be laughing without any reason. Incoordination of movements, poor school performance due to the problem in the handwriting, and uncontrollable movement. Sometimes they can drop a glass of water in the house as well, and the facial grimacing exacerbated by stress and disappearing with the sleep arthritis. So they are not present, these movements are not present during sleep. Although the acute illness is distressing, chorea rarely, if ever, leads to permanent neurologic sequelae. So what does it mean? That the problem is definitely a kind of stigma for the patients, for the if they appear to the relatives, they can be embarrassed with the involuntary movements, but it rarely leads to permanent neurological damage. So most of the cases will not have any brain damage, and that would recover with the passage of time with the treatment. This is the different types of dancing movements of chorea. Erythema marginatum as a skin manifestation is less than 3% of the patients with acute rheumatic fever, but characteristic rash of acute rheumatic fever. So you can see the erythema marginatum with the erythematous patch and the central clearing. This is the erythematous patch, and central is pale clear. Subcutaneous nodules present less than 1% of the patients, but there is a correlation between the presence of these nodules and significant rheumatic heart surgery. These are the nodules. So all patients with acute rheumatic fever should be placed on bed rest and monitored closely for evidence of carditis. They can be allowed to ambulate as soon as the signs of acute inflammation have subsided. However, patient with carditis require longer periods of bed rest. So in treatment, uh, besides the bed rest and the conservative management, once the diagnosed acute rheumatic fever has been established, regardless of throat culture results, the patient should receive 10 days of orally administered penicillin or erythromycin if the patient is allergic to penicillin, or a single intramuscular injection of benzathine penicillin to eradicate group A streptococcus from the upper respiratory tract. So either 10 days of oral treatment with these two antibiotics or a single intramuscular. But this, after this initial course, the prophylaxis on long-term prophylaxis would be given in the form of more usually an injection of benzathine penicillin in a month. So treatment is usually with the salicylates and corticosteroids. And the patient with typical migratory polyarthritis and with those without with carditis but without any cardiomegaly or congestive heart failure should be started with oral salicylates. But what does it mean? The simple cases of arthritis and carditis, but there are not any manifestations of cardiomegaly or there is not any manifestation of congestive heart. They should be started on the oral salicylates. And the patients with carditis and who have developed the cardiomegaly or congestive heart failure should receive corticosteroids like prednisolone. So I've written the doses, but you don't need to remember the doses exactly. The chorea, because chorea often occurs as an isolated manifestation of the resolution of acute phase of the disease, anti-inflammatory agents are usually not indicated, but definitely the prophylaxis is indicated in the form of injection of benzathine penicillin every month. The treatment of sedative like phenobarbital and haloperidol chlorpromazine for chorea is effective in most of the cases. Not all these medications should be given, only one medication at a time, one time is necessary. So primary prevention, if we talk about prevention, primary prevention, appropriate antibiotic therapy instituted before the ninth day of symptoms of acute group A streptococcal infection is highly effective in preventing first attacks of acute rheumatic fever from that episode. What does it mean? Like if some kid has developed sore throat and sore throat is due to some bacteria like group A streptococcus, we should give early antibiotics, should not delay the decision of antibiotic like this part of the world, Pakistan and subcontinent. We should give the first dose of antibiotic before the ninth day of the symptoms to prevent the first attack of acute rheumatic or to prevent the acute rheumatic fever. But once the rheumatic fever is there, we should give the secondary prophylaxis for the prevention of recurrence. So this is usually in the form of antibiotic therapy immediately, which we give a full course of antibiotic therapy, and then we give the regular 1 monthly dosage. So secondary prevention is directed preventing acute group A streptopharyngitis in patients with substantial risk of recurrent acute rheumatic fever. Secondary prevention requires continuous antibiotic prophylaxis, which should be given as soon as the diagnosis of acute rheumatic fever has been made and immediately after a full course of antibiotic therapy has been completed. So secondary prevention is like penicillin in the form of injections, which I have already told you, like penicillin, benzathine penicillin. We also call it penicillin G, benzathine, and 6 lakh international unit for children less than 60 pound, and 1 lakh 20,000 or 1.2 million unit for children more than 60 pound every 4 weeks. So in 1 month, one injection and intramuscular. If due to some reason the patient is not taking injection, we should give penicillin V orally, and or sulfadiazine or sulfasalazole. For people who are allergic to penicillin and sulfonamide, should give macrolide or azolide like erythromycin. Secondary prevention, as I already told you, is for uh, years and years, and every month there should be one injection benzathine penicillin. So there are different category. So this is also one of the exam questions, so you should memorize this table very carefully. Rheumatic fever without carditis in a simple patient, when which is the patient is diagnosed with the rheumatic fever and there is no carditis, we should give 5 year or until 21 year of age, whichever is longer. So in a patient who is a patient of rheumatic fever, like with arthritis or something, but there is no evidence of any carditis, we should give antibiotic prophylaxis every month until 5 year or until 21 year of age of the patient, whichever is longer. And similarly, in a patient who is diagnosed with a rheumatic fever with carditis but without residual heart disease or no valvular disease, we should give antibiotic prophylaxis for 10 years or until 21 year of the age of the patient, whichever is longer. Rheumatic fever with carditis, and also there is residual heart disease or persistent valvular disease, we should give the prophylaxis for 10 years or until 40 years of age, whichever is longer. Sometimes lifelong prophylaxis is required. Prognosis nowadays with the presence of antibiotics is good if the antibiotics are instituted early, um, and we can prevent the rheumatic fever, and if the rheumatic fever has been there, then we can give secondary prophylaxis to prevent the recurrences of the rheumatic fever and to prevent the complications of the rheumatic fever. So generally, if we start therapy, the prognosis is good, and if we start prophylaxis, the prognosis is good. So with this, thank you very much. If you need any questions, you can ask in the YouTube comment section. Thank you very much.